Hello and welcome to the first Respiratory Futures podcast. Today we're talking to Professor John Stradling and Dr. Sophie West, both of whom are respiratory physicians specialising in sleep. They're here today to talk about a campaign to fast-track treatment for vocational drivers with sleep apnea and to respond to any questions you may have on the subject. Welcome to you both. So why don't we kick off if you could just give us some more information about what exactly OSA is.
I think most chest physicians now will know what sleep apnea is. 20, 30 years ago it was a bit of a rarity and people thought it was pretty unusual, but we now know that the prevalence of significant obstructive sleep apnea is certainly in the region of about 5% of middle-aged men and women. The exact prevalence it really depends on your definition, but I think 5% feels about right for people who have a problem related to sleep apnea, which is usually daytime sleepiness. I think one of the reasons we don't fully know the prevalence is that quite a lot of people don't get diagnosed because the dominant symptom of sleepiness is pretty non-specific, and there are a lot of people out there, probably about 4 or 5 times the number who've actually been diagnosed, who are going around with undiagnosed sleep apnea. So we've got a long way to go in terms of getting everybody who needs treatment on treatment, that's for sure. Does that sort of number feel right to you, Sophie? Certainly, I think in Oxfordshire, we've probably only diagnosed about 1/3 of the likely population.
Yes, I think that sounds very typical. I work in Newcastle, and one of the things we've found is, as you say, sleepiness is a non-specific symptom, and many middle-aged people think that's just part of getting older and that's normal for them and their stage of life. But when we do diagnose sleep apnea and treat it, they realise actually things can be very different, and sleepiness is reversible with treatment, but they haven't necessarily presented with those problems.
Yeah, no, agreed. Certainly, I think one of the issues that has bedeviled this area is that there is a difference between sleep apnea that you see on a sleep study and the full-blown syndrome where you have an abnormality at night and you have consequential symptoms during the day. And it's certainly been shown that many people have sleep apnea on a sleep study but appear to be completely symptomless. And so we do make this differentiation between obstructive sleep apnea, which is what you see on a sleep study, and obstructive sleep apnea syndrome is the combination of an abnormal sleep study and significant symptoms. And I think we know that it's probably quite dangerous for people in a number of ways, certainly car accidents, that kind of thing, road traffic accidents, falling asleep at work. If you have a vigilance critical job, then that can be really bad news, extending right up to the possibility that it raises cardiovascular risk and may be a cause of increased strokes, heart attacks, etc., although to some extent that's still debated. From the patient's point of view, immediately it's the quality of life issue, which Sophie's just mentioned, that for me has always been the main driver for getting patients treated. Sleepiness doesn't just affect driving, it affects your whole quality of life. And I think that's one of the reasons that people are drawn to this area. It's one of the more rewarding areas to be involved in medicine.
Yes, I agree, and it can be, people often describe treatment for obstructive sleep apnea syndrome as life-changing, don't they, John?
It's certainly the most dramatic condition that I've treated over my years as a chest physician. I can't really think of any other outpatient abnormalities, as it were, that are so gratifying to treat. It's been quite an honour to be able to treat so many patients and make such a difference to their lives. People often ask, does it really matter that these patients are a bit sleepy? Aren't a lot of people sleepy? But I think the fact that it contributes potentially to motorway traffic accidents is something that's made a lot of other people who are not normally interested in sleep apnea become interested. The DVLA are certainly pretty interested in this area, although they seem to have made a bit of a mess recently of the guidelines as to how to handle it. But it's certainly an area that is currently in major debate. And I think the next slide is going over some of the issues about what happens when a patient is diagnosed with sleep apnea and symptoms sufficient to impair driving. And I think up until quite recently, we had a reasonably good way of handling this, in that if the sleep apnea didn't cause sleepiness sufficient to impair driving, then the DVLA were not particularly interested and the patient did not need to notify the DVLA. But if the symptoms did affect their driving, then they had to stop driving and inform the DVLA. This has become a bit blurred recently, and we might get on to discussing that, although hopefully the DVLA will change it back to how it was before in due course. And I don't know, Sophie, whether you find that driving is one of the issues that's hardest to handle in the clinic. It's always been the one that, for me, has been hard to handle. It can upset the doctor-patient relationship when you start discussing whether they should be driving or not.
I think that's right, John. And I think people have often come and may have been told by their GP to stop driving, and if they aren't people who have daytime sleepiness sufficient to impair driving, that's then weeks of driving they've missed until they're seen in hospital, and they may be pretty fed up about that when they attend. So I think we've tried, haven't we, in the clinic, to differentiate those people who are sleepy enough to be impaired with driving from those who, as you say, have milder sleepiness syndromes and it probably doesn't impair their driving. And we try to tailor our advice according to the patient in front of us.
It's quite interesting that in medicine we're doing this all the time. You know, if somebody has got a neuromuscular disorder, somebody at some stage has to decide they're not safe to drive, and these are grey areas. But it's been interesting how some people want some kind of hard definition of whether you're sleepy enough to stop driving or not, but it's just not that simple. Much of it depends on the patient's attitude to their sleepiness. If they're very worried about it, they're going to be a lot safer than if they're rather blasé about it. So it's quite a complicated area. The American Thoracic Society produced some guidelines a couple of years ago, which I thought were very sensible, and discussed ways in which you could try and assess a driver and decide whether they were probably okay to go on driving or not, which of course involved talking to relatives and things like that. But if once a patient knows that their license may be under threat, it's not surprising that they may not want to go and see their GP and put up with the symptoms and therefore be at risk. And I think it's a failure of the NHS so far and a failure of doctors to realize that treating patients whose livelihood depends on driving is almost an emergency, because if you don't do it, they're not going to present and they may go on having accidents, which if you're a big heavy lorry driver is really bad news.
Yes, and I'm sure we've both seen people in our clinics with terrible stories about that, haven't we? Where they've been sleepy, they didn't want to present, they kept on driving and driving HGVs or buses with potentially devastating consequences. And these cases really stick in your mind as a doctor of an area you want to improve care and improve their access to treatment for obstructive sleep apnea so that they become safe drivers.
One of the first times I became aware of this was a bus driver in Oxford who, when he had been treated, said, look, I've got several mates who do exactly the same as I do, and I've talked to them and I know they've got sleep apnea, but I can't persuade them to present to their GPs because they're so worried. And so, you know, even in the clinic we hear stories of people who clearly are not coming forward.
Yes.
So this inaction, as on the slide, is potentially devastating, and that's one of the reasons why the OSA partnership group has been foremost in trying to raise this issue and introducing what we called our four-week wait campaign, which is on the next slide, I think. there is a 2-week wait campaign for people with cancer, or a way of handling people with cancer where they have to be seen within 2 weeks. So we've sort of capitalized on that concept of demanding that people get managed within a certain time frame so that they are confident that they can come forward. The original aim of the OSA partnership group was really to raise awareness of OSA within the general population, but in particular with transport organizations and people involved in commercial drivers. And so this campaign is sort of part of a bigger campaign for fast-tracking the treatment of commercial drivers. And even if we do this, I know there are still going to be drivers who are a bit reluctant to come forward, but I think once everybody knows that this 4-week wait is in place, should we achieve it, I think more drivers will come forward and accept that it's worth coming forward and safe to come forward.
And just to clarify, John, the 4-week wait, what does that refer to?
Well, the 4-week wait, we hope, encompasses from the very moment the GP decides that this patient is a candidate for this issue and decides to refer them to the hospital. And then the clock starts ticking at that point. And the 4-week is hopefully when they have had treatment, have responded, and are now safe to get back on the road. And most people felt that 4 weeks was doable, even within the NHS, as long as everybody was willing to make it work. And certainly that, in our area, has been a little bit of a problem, and I've heard in other areas it's been a little bit of a problem trying to run a service that responsive. And the sort of problems that people have said to me is, well, you know, we might have to keep spaces for these patients, and then if they don't come, we've got empty slots. But I think it's just a question of having the will to do it. And I think the next slide describes Sophie's approach to this and what she's been able to do at the Freeman. And perhaps, Sophie, you could just take us through what you managed to do and what the problems were and how you overcame them.
Yes, thank you. So when we heard about the OSA Partnerships Group 4-week wait target for professional drivers with obstructive sleep apnea, we decided we would start putting that in place in our own hospital, really to see if we could achieve it, and then with a wider aim of sharing those results nationwide. So I work with 2 sleep nurses, Mark Tomlinson and Gillian Olds, and they have been the key people who have seen professional drivers. So what we did was we contacted the local GPs via the Trust newsletter to advertise this service and explain what it was, and to stress the importance of the GPs identifying professional drivers in their referral letter so that we could move them through the fast-track driving system, as we've badged it. And it's much better for GPs to refer people directly, to fax their referrals through, rather than putting them through the choose and book system. So if GPs could identify these patients, we would then badge them as fast-track drivers, and Mark and Jill have had 2 slots each week which they have set aside to see professional drivers. They see them, they do a sleep study that same night, and then see them again the next day, and if necessary start CPAP the next day. And then they have a follow-up slot booked a week later where they would see people to ascertain their progress with CPAP, to determine whether their sleepiness had improved and whether they were safe to drive again. If the slots hadn't been filled each week, our administrator, Joan Furness, has always got people ringing to find out where their appointments are, and she, a few days before, if the slots aren't filled, she fills them with someone else, a non-fast track driver. So we haven't found we've lost any slots, more that we're using the slots we have in a slightly different way, in a more proactive way. And it's been extremely popular with patients. I think, to know there's a fast track system and to know they're being prioritised as drivers. The only thing to say also is a lot of our driver patients, it wasn't formally identified to us that they were professional drivers until they attended their routine choose and book appointment. And at that point, we then moved them onto a fast track system to try and get them through and driving again quickly. But clearly, if the GP can identify this, and hopefully if drivers are aware of this and ask for a fast track review, then things can be expedited for them.
No, this is excellent, and it's a good example of where if the will is there, then it can be made to happen. And I think there are now centres around the UK who've realised that this is the right thing to do. And it's been quite gratifying that NICE, on its website, it has a system where they describe clinical scenarios to help GPs and others think through clinical problems, has made it quite clear that a GP's responsibility when they get a patient like this is to ensure that they make personal communication with the sleep unit and ensure that the patient is going to get some kind of preferential treatment, preferably within a few weeks. So NICE, to some extent, is backing this approach, which is very helpful. And it will be interesting to see how many centres now claim that they can do a 4-week wake strategy for patients. I wrote a recent article for the British Journal of General Practice in which this issue was discussed and raised, and there has been a little bit of interest, but I'm not quite sure how we can gauge whether enthusiasm is sweeping the country or not, I fear.
And one thing just to stress from our experience is having this fast track system doesn't represent any extra work, and I spoke to all the people involved in it yesterday who confirmed that. It's just doing the same work but prioritising this group of patients for certain slots. And we haven't found, I mean, you'll see our numbers on the screen, it wasn't enormous numbers of patients, so 2 slots a week reserved for fast track drivers seemed to be adequate. And clearly if we were filling all of those easily, we'd highlight another slot or 2. But it's not been a major workload issue.
And I think that workload sort of roughly agrees with our back of envelope calculations as to how many drivers, professional drivers, a sleep unit of your size might see and therefore need to cope with. And although it's smallish numbers, it's a lot of lorries driving around the country potentially and having accidents. So it's well worth doing despite the apparent small numbers. And because it's clearly small numbers and so easy to do, there really is no excuse not to do it, in my view.
Great. Well, thank you both so much. It feels like a good point to segue onto some questions that we've received from our audience. One of which is how do we encourage GPs to take part and actively refer these patients for fast tracking? I mean, you have touched on that, but if you could sort of sum it up, what would you say?
I mean, one of the problems, my wife's a GP and they get bombarded with endless encouragements to do this, that and the other, and it's quite difficult for them, I think, to prioritize. But we think this is important enough to try and persuade GPs to remember to do. It's not difficult, it's not complicated, it's well worth it for patients. So I think articles in their magazines, in their academic magazines, in their sort of rags that they get, talking at meetings, doing what Sophie's done, which is communicate with the GPs through the hospital newsletter that goes out. There doesn't seem to be a coherent countrywide way of giving GPs direction and advice. It's probably because it wouldn't be popular. So we have to just keep trying all sorts of strategies to raise awareness and to let people know that this fast tracking system should be in place in their area.
And I've certainly been on some GP, I've been invited to talk about sleep apnea on GP study days or conferences. So I think it's a case of seizing all those opportunities to increase interactions between primary and secondary care.
Which unfortunately, with the recent developments, I think, in the way the NHS is run has decreased badly. You know, you don't now get referrals from GPs to specific consultants, they just come to departments. And we used to have quite good relations with our GPs, which have gradually been broken down, and we almost work in isolation these days.
Agreed.
Perfect, thank you. We have another question. It says that arguably our biggest problem is when patients don't comply with treatment. What recommendations do you have for managing these situations?
Well, I'm sure, like Sophie, you have to have some highly qualified and dedicated staff who know how to solve patient problems before they become so bad the patient throws in the towel and says, this isn't for me. And we know that compliance is very different in different areas depending on basically how much effort you're prepared to make. And when your team are overloaded and having to do far more than they should, then unfortunately corners get cut. And we do hear about centres that almost just give people treatment in a box and tell them to go away and read the instructions, as opposed to doing a proper induction for the patient, which may take, you know, a good hour or so to satisfy the patient. He's had all his questions answered, he knows how to handle it, knows what to do if things go wrong, what to expect. This isn't a trivial treatment. It needs to be delivered in a proper way. And I'm sure Sophie has, like us, has set up systems that ensure that, you know, patients don't just give up for no good reason. There will always be a hardcore who find it very difficult. And there are other treatments apart from nasal continuous positive airway pressure, which we haven't spoken about, but I'm sure most people know about. It is a difficult treatment, but most patients with sympathetic handling are able to cope with it, certainly the more symptomatic ones, which are the ones we're worried about. Sophie, have you got any tips and advice for people who are having trouble getting their patients onto CPAP?
I think it's just as you say, John. We have very good nurses and physiologists who are experienced and do all the CPAP initiation. Patients will get a information sheet to take away, sort of reiterating the points that have been gone through verbally. A early follow-up, I think, is crucial, or access to a helpline just for troubleshooting. We all know the nights can be long, and if you're trying to get used to CPAP, the nights may be even longer. So having a helpline you can ring for advice the next day, I think, is very valuable for patients. But we would want people to have had a really good go with lots of intervention from trained staff before they decided it wasn't the treatment for them, because I think most people can get established on CPAP and use it well in the long term, although they may have a lot of teething trouble at the beginning.
There is new technology about, which is quite smart, where you can now monitor what's happening to a patient on CPAP remotely with a wireless technology to a central station, which does allow the clinic staff to help a patient resolve problems over the phone by looking at these records immediately without asking the patient to have to come into hospital and miss more time at work, etc. So I think this so-called remote monitoring is something that's going to become quite common. It's not that much more expensive, but I think in the long run it will probably mean more patients are established satisfactorily and happily on CPAP, and the service that we as a clinic can provide is more responsive.
Great, and let's just round off with the final question, which, John, you have already touched on briefly. Is this an area where NICE should be taking the lead?
I think so, because at the moment recommendations by NICE is what most CCGs hide behind when they don't particularly want to do something. They say, has NICE recommended this? Have they ruled on this? What are the guidelines, etc.? And although we have a technology appraisal saying that all patients with symptomatic sleep apnea should be given the opportunity to have a trial of CPAP, there are no actual guidelines out there directing doctors, etc., how to deal with the patients right from the moment they present. And I think once there are such guidelines, it'll be easier to talk to CCGs and GPs and discuss how they're going to follow these guidelines. The trouble is the guidelines are probably going to take another 2, maybe even 3 years to come through, and I'm sure they'll include things like 2-week or 4-week waits rather for lorry drivers, etc. But a lot of accidents can happen before then, which is why we're quite keen to try and get the 4-week wait in place long before the guidelines might finally come out.
And I think clearly we have a postcode prescribing, as it were, or postcode access at the moment as to what you get in different locations in the country, and that was what NICE set out to get rid of. So I think I would agree with you, John. I think NICE do have an important role here in obstructive sleep apnea.
Thank you.
So we look forward to their guidelines in due course.
Absolutely. So this concludes our first podcast. Firstly, a huge thanks to John and Sophie for being able to take part. I hope that everybody has enjoyed this, and if you have any follow-up questions, I will leave details underneath where this is saved on the website for you to leave, and we can then follow up with John and Sophie in due course. Many thanks.